Welcome to All Things Policy, a daily podcast by the Takshashila Institution. We are a bunch of policy nerds based in Bengaluru, and we like bringing fresh perspectives to Indian affairs and Indian perspectives to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hello, everyone. Welcome to this episode of All Things Policy. I'm Suman, your host for today. I'm joined by Shambhavi Naik, chairperson of the Advanced Biology Program at the Takshashila Institution. Welcome to the show, Shambhavi.
Hey, Suman. Hello, everybody. It's been a while since I've been on the show, so it's nice to be here.
Great. Okay, just for a short introduction. I'm sure all of us, we all know, in the last few days, the news cycle has been dominated by the Iran, US, and a supposed nuclear war that we came so close to, but thankfully did not happen as of now. Now that we have survived that, I thought we could move on to other equally important topics. The first one being BIRSA101, a gene editing therapy to treat sickle cell disease. The therapy was launched in November 2025 as India's first indigenous CRISPR-based gene therapy for the disease, with a technology transfer agreement to Serum Institute of India for scale-up and translation. This has been framed as both as a public health milestone as well as self-reliance or Atmanirbhar Bharat milestone in advanced therapeutics. Now, if this is sounding all too complicated, I tell our listeners to fear not. That's what we have Shambhavi here for. She will break this down for us in very simple terms, I'm sure. Shambhavi, for our listeners, firstly, let's begin with what is sickle cell diseases? What are traditional treatment options per se?
Wow, Suman, for a second there I thought talking about the war might have been easier than talking about disease 701. But anyways, to happy tidings then.
Yeah.
So sickle cell anemia, which is not the happy tiding BIRSA is, but anyways, let's talk about the war on disease first. So sickle cell anemia is disease of the blood cells in which blood cells are not correctly formed because of a genetic mutation. And as a result, the people who suffer from, and they look like a sickle then that's used in farms, right? So it's called sickle cell anemia. As a result, people suffer from very debilitating symptoms, are unable to go around with healthy, productive, normal lives. In India, there are about 1.2 million cases of sickle cell anemia. Roughly 40 to 80,000 children are born annually with some spectrum of the disease. And what is quite unfortunate is that it disproportionately affects people from tribal backgrounds. So not only are these people then disadvantaged historically, but also because economically it is very difficult for them to be able to buy the treatments available. There comes a double whammy of issues. The reason the kind of treatments that are right now available, you can manage the disease through continuous lifelong, say, blood transfusion or hydroxyurea administration. So the hydroxyurea administration is a daily dose that you have to take for your entire life. Or you have to have continuous blood transfusions, which, as you can imagine, are not that easy.
And I would also imagine not safe in all parts of the country.
Not except when you're also looking at disadvantaged conditions. The only known cure right now, and before CRISPR came along, was to do complete bone marrow transplant, hematopoietic stem cell transplant, which is again not at all easy. You have to find the correct donor, they have to match, so very grueling surgery. It has to take on survival in the host. The host cannot reject it, etc. There are a lot of scientific and technological issues there. And in India right now, that costs about 30 to 40 lakh rupees.
Okay.
But that's the only kind of, when it works, and then you don't have to go back to trying to manage the disease, right? So it is not easy having sickle cell anemia. The Indian government has really prioritized sickle cell anemia because of its health equity reasons. We run a massive screening program for people to be able to diagnose sickle cell anemia. One of the outcomes from this is obviously so sickle cell anemia, like many of these diseases, happens when both partners have the disease mutation and pass it on to the child. Right?
Okay.
So the child needs to have 2 copies of the bad gene. So the screening helps in identifying which couples are likely or which children are likely at risk and can be offered counseling, can be offered basic treatment by choosing the correct healthy embryo so that the child doesn't suffer from sickle cell anemia. But because it is also very common in a certain population, it means that the population is more at risk of the disease. So in all of this, CRISPR actually creates a really new avenue for how the populations at risk can think about going around their lives with a cure, not only for them, but for the future generations as well. So I think that's really bringing a new hope.
Okay, so now that you have told us, now what changes in the sense that what has changed with this new tech? That is, you're changing the gene itself. Is that what it is?
Yes. So the Indian technology transfer that happened in the end of last year involves an indigenously developed version of CRISPR. The world's first sickle cell anemia treatment using CRISPR has already been approved in 2024. Late 2024 in Europe and the US. That's called Casgevy. And so we have already started working with this idea that we can go inside human cells and be able to correct the mutation and put those cells back in, which is like fantastic, right? I mean, you can take someone's cells out, you can correct the mutation, you can put the cells back in and hope that, not hope, but show that the body makes enough of the good blood cells for the human to operate as well as the others. So that's actually quite fabulous.
Okay, that's the gene editing part of
Yes,
this.
that's the CRISPR part of it.
Yeah, just to take a step back, I mean, there are lots of, I just want for us to reiterate to our listeners, gene therapy, there is a lot of misconception or some kind of misunderstanding of the entire concept itself. So, what, according to you, what are the pros or what are challenges that also, I mean, we should look at both sides of gene editing and gene therapy as such. So, what could be, what you've explained definitely the advantages. If there are more, please go ahead. And what are the counter arguments and how good or bad are they?
So, I mean, gene editing is quite new, and we are working inside now. Even if you take the cells out, you treat them and you put the cells back in, they're still genetically edited cells within a person's body. So, it's a little difficult to control their interactions within the body. And for every set of new genetic signatures that we come across, so like the American people are very different from Indian people genetically.
Yeah.
In India, there are like thousands of genetic subgroups of people, right? So how one of those gene combinations will react is impossible to call out right at the beginning, right? Unless you do a clinical trial, which is what will happen with BIRSA now. So what has happened so far is the technology transfer. What will happen now is the clinical trial to really show how good the treatment will be in trying to alleviate the symptoms of sickle cell anemia. In India, it becomes a select subpopulation because that's higher at risk. But only those results will show how good or effective the treatment will be, right? Or if there is going to be involved. So because it is fairly new, I think that risk is something that we have to be able to prepare and mitigate for. Obviously, it is scientifically safe, but there are limits to which we can test anything that's emerging. The other will be cost. Casgevy, for example, is like $2 or $3 million, which is like very expensive. We still don't know what BIRSA will be priced at. There have been some reports that it will be around 50 lakh rupees, and they're going to try and drive it as closer to a bone marrow transplant cost as possible, because that's really the alternative that you're looking at, right? So your alternative treatment for sickle cell anemia, like a cure, is the bone marrow transplant. So as long as we can make CRISPR-based treatments as economically similar to that, the price similar to that, we're probably in the game. But if we don't make it in-house, if we wait for others to do it, then economically it would be very difficult for the average Indian to be able to buy some of these treatments.
Okay. So just going back to the public policy part of it, often we make the distinction between healthcare and public health. Healthcare is individual, whereas public health is more, more for the public, making things like sanitation, things like, things that affect a larger group, or even vaccinations are considered public health, whereas a one-to-one interaction that does not affect others are healthcare, right? So in this instance, what is the case for government intervention? I understand the equity part of it, but otherwise, what is the case for government intervention? Because this is not so much a non-communicable,
a communicable disease.
A communicable disease here. I mean, one interaction with it does not affect the larger population, right?
Sure. I think there are two reasons for why the government has been involved. The disproportionate impact that the disease has on particular tribal communities, and the fact that they are disadvantaged to be able to actually access healthcare on their own, right? That makes it a health equity question, and therefore of within the government's purview. The other is that while it is not communicable, it is definitely hereditary. So because it will come from the parents, right? And because again it is community based, and we often find community members marrying within the community, it increases the chances of those tribal communities actually having children with more and more sickles, having more and more children with sickle cell anemia. And that's why screening was introduced to help make more informed decisions. And that is why the government's continued intervention in trying to promote a technology. And I mean, I think so the government, the work that led to the technology being made was funded by the government. It's now been taken up by Serum, like you said, right, for further exploration and then eventual manufacturing. Not only that, there's this massive idea. I mean, the sickle cell anemia, I think, is just the beginning.
Yeah.
If we use indigenous backbone like the FNCAS9, which was developed by IGIB for sickle cell anemia, and it works, there's a number of other diseases that we can think about making treatments for indigenous diseases which might only be more prevalent in India and might even not be considered by other countries, right, as something that needs to be targeted. So there is a massive spillover effect of the governments involved in developing the initial technology.
Yeah, that's where I was going from here to just state that, any kind of research, investment in research as such, in any of these kind of things, will build the infrastructure first for research itself, will probably provide material or probably provide interconnections that can be used for further research. And because this is funded by the government, it becomes a public health, or maybe not in the classical sense of the term public health, but it becomes a public initiative. And therefore, it is important for analysts like us to be studying this at least studying the government action on this a little more, in detail.
Sure. Let me just add, so the government actually a target for sickle cell anemia alleviation in India. So the fact that the government is promoting emerging technology to be able to actually reach this target is quite nice.
Yeah.
We have been trying to raise the kind of standards of medical care that we can access in India. I think this step is going to go a long way on that journey.
Yeah. So again, just to digress a little, we have been discussing this at work too, about vaccinations for vaccine production for indigenous diseases and all of this, right? Malaria or chikungunya or dengue or any of those things. Now, those are, vaccine development. And I think there are lessons to be learned from there too, bring into any kind of research, and just to drive home how important it is for indigenous, for us to be studying diseases, like that are more prevalent in India, because nobody else would do it, right? But what is the role of private sector in this? Like, if why should Serum Institute actually take this up? Because there doesn't seem to be a market for this. Because if we are talking about this thing affecting the tribals and people who really cannot afford this in whatever way, at the price point that they will probably put it.
Sure.
What is the incentive for them to be here?
That's a good question, Suman. And I actually don't know. I assume that the government is going to be the end buyer.
Okay.
I assume so. I don't know. Because this will come under one of the tribal welfare programs. So my expectation is that it will be available, obviously, in the public market. There are other people who, including some of the tribal populations, can afford to buy the therapy once it becomes available. But I've also met a lot of patient group representatives from the sickle cell anemia community. And it's a very active movement, right? They're very, very self-aware that there are therapies available, that those should be made accessible in India. And then money is really something that can either be raised through the community or through government or through other sources. So right now, the health of the children seems to be their biggest priority. I'm sure the government will have a role in the actual procurement and dispensation of the therapy once we go through clinical trials. I'm sure the fact that the research was funded by the government will hugely subsidize the cost of the therapy eventually anyways. So, and right now we're looking at something that is roughly 6 to 8 times cheaper than the currently available alternative. So,
yeah, and if this is, predominantly affecting the tribal populations, we should see at least some improvement in terms of, survival rates of children
yeah,
in those populations. And that is a government imperative, I think, to ensure that these people actually just don't fall off, because there is no treatment available, or there is no, and having known about this disease for the longest time.
Yeah, I think I was once talking to once at a conference in which the sickle cell anemia problem was talked at extensively, and I think one of the things that came forward when talking the to the patient group representatives was that they get often told that, why don't you marry outside the community?
Mm-hmm.
Right? Why don't you marry outside the community, because the disease is so prevalent here? And I've got trolled extensively for an opinion piece I once wrote many, many years ago, saying that Indians should marry outside caste to make sure that, genetic diseases which have come through years of endogamy don't continue to propagate, right? But what one of them once told me has stayed with me, and they said that, look, it's not only about the disease, it's also that there are our practices and our identity as a community, and we risk to lose that if we
marry outside.
Yeah. And so it is not just about having healthy children, but it's about having healthy children who identify as part of our community. That feeling is very strong. And I won't say it's for everybody, but at least for this one person that I was talking to, it seemed to make a difference that what they want is healthy children of their community. That's the future that best resonates with them.
Yeah, I guess, leaving them out, even outside, fairly progressive people, the need for being with your own community, the need for being with likeness, or all of that, when it is so present outside, I don't see why we should be as fairly, supposedly progressive, whatever. Why should we be preaching to them about a certain way of life? If it happened in progressive communities, or if it happened, or in supposedly forward communities, I am sure we would have still tried to find a cure for that disease.
And there is really, really, really hope for these communities, right? That they can continue being, true to their history and their culture, and have healthy children who can continue to take that legacy forward.
Yeah. So I think it's just not about, there are so many aspects to it. It's just not the science. It's just not the cost. It's not the government or anything. There are so many social aspects that come into this. And that's what makes it a more complex public policy problem itself, I guess. So what do you think is the way forward for this particular, what can we see in the next few months, at least, for this particular disease? And generally in terms of indigenous research and, those technologies that we are talking about.
For the BIRSA101, and I think we should give due respect and maybe talk very briefly about BIRSA, and
that's where
after which the therapy was named, which I think I saw a lot of happiness when it got named after the leader.
Appropriate.
It was quite appropriate. So for BIRSA, we'll have to see what the clinical trials do. It all comes down now to the clinical trial and how effective it will be. After that, I think it would just be, in the time it takes for the clinical trials to be done, we'll probably start seeing further fall in the prices as well, because the technology is progressing everywhere. And I think that's really good for medical science. So then it's going to be a point of, how do we subsidize the actual treatment out to everyone who needs it. But that's, I think, a fairly easy policy question to solve.
Yeah, we've done it earlier.
Yeah, if we put the mind to it, I'm sure we can find the money. It won't really be that big a number anyways. Not like you and I can fund it, Suman, but in terms of government funding, I think it should be.
Yes.
It should be pretty reasonable.
Let's see if we make it an election promise at some point.
health being an election promise, the day that happened, Suman, it did not happen after COVID. After COVID-19, nobody seems to care about health as a manifesto issue. It's unlikely to be one now, but who knows? Anyways, if it gets the job done, it gets the job done, I guess.
Whichever.
But if it works, right? We have another clinical trial for hemophilia, which is happening in Vellore. That's not an indigenous technology. That was from it's a collaboration with the NIH. But if both of those progress well, right, in terms of actually building capacity within...
Okay, NIH, the acronym doesn't, for people like us.
National Institute of Health in the US. So if both go well, we'll start building capacity in India for actually researching diseases, being able to think about how we can formulate CRISPR-based therapies for those, manufacturing and clinical trials. Right? All of this is a brand new space for Indian governance to actually look at, the import of some of these raw materials, the way clinical trial outcomes have to be judged. A lot of these are going to be new things because it's an emerging technology. And once we build that capacity, I think we should be able to fast track and really expedite a lot of indigenous development, particularly because we already have the FN-Cas9, which IGIAB has developed. We need to develop more variants like that. That's the first step. Because right now, before FN-Cas9, we were importing a lot of so Cas9 is one of the enzymes.
Cas9.
Whenever you say CRISPR, it's supposed to be CRISPR-Cas9. Cas9 is one of the enzymes that is involved in the process of editing the gene. If India imports that, then there obviously has to be royalty, etc. Developing that indigenously is what is the change that this one therapy is going to look at. But we can develop more of such gene editing tools. That's the beauty of biology. There's a lot out there that needs to be explored and, for the lack of a better word, exploited. So that's where we are at. I think this is going to bring in a lot of hope for a lot of people, not just the sickle cell anemia sufferers, but for a lot of genetic diseases that are prevalent in India.
Yeah, so that's a hopeful note.
I don't know why we don't do more biology and hopeful conversations than Iran and war. And
I know. No, I'm saying we started off thinking that, this is a podcast about disease, but actually we are going towards, curing or finding solutions to the disease, and that is
eventually cancer.
Eventually
we start from single cell mutations like sickle cell anemia and thalassemia, but finally cancer is also genetic disease. So eventually the hope is to be agile enough to be able to cure cancer.
On that very, very hopeful note, thank you for joining us, Shambhavi. Thank you all for listening, and join us again for another episode. I'm sure Shambhavi will be watching this space very, very carefully, and we'll get her back in a few months' time when there are more developments. Thanks, everybody. Thank you, Shambhavi.
Thank you.
If you liked our show, dive into Takshashila's research on technology, strategy, and economic affairs. Check us out at our Twitter handle @Takshashila INST or our website takshashila.org.in.